Uh, Good evening, everybody. I want to welcome us once more and once again to our bi-weekly presentation. So on today's Monday presentation with us is Mr. Joshua OLUALA. Mr. Joshua is a senior colleague and will be taking us on the principles of electrosurgery. Can we all hear me?
Oh, yes.
Am I audible? Okay. All right. Thank you so much. Thank you. So Mr. Joshua will be taking us today on the topic, the principles of electrosurgery. And by introduction, Mr. Joshua OLUALA is an RON, ROPON, that's a registered nurse, a registered perioperative nurse, and BSc nursing. He worked as a perioperative nurse in Lagoon Hospital for 5 years, where he then moved to Evercare Hospital and he was the operating theater manager and a greenfield project expert in the development of SOP, the standard of practice, pathways, and operating room protocols. Currently, he is in the United Kingdom, and we have the opportunity to have him in our midst today to take us on this topic, and we look forward to learning from him. So I want us all to engage and make the meeting an interactive one as we start. Welcome, Mr. Joshua. You have the stage.
Okay.
Welcome.
Thank you very much, and good evening, everyone. I hope our day has, been a productive one. So very quickly this evening, we're going to be looking at the principle of electrosurgery. So I'm going to share my slide. I'm going to share my slide now on the. Yeah. Can we see the slide? Hello, can you hear me? Hello?
No, we can't see this. Yeah, I think it's starting to come up.
Okay.
Yes, we
Can you
can.
see it now?
Yeah.
Oh, thank you so much.
Thanks a
Thank you
million.
very much. Yeah. So, once again, good evening, everyone. It's going to be a very quick and, of course, brief one, just to, remind us of some things, because this gathering is a gathering of theater users, and of course, this is not a new topic to us. So, my name is Joshua. Okay, well, before I start, let me just say beforehand, I have a little girl here that can just make an unnecessary shout, anytime. So please bear with me. My name is Joshua OLUALA. I'm a registered nurse, a perioperative nurse, and a BSc nurse also from Babcock University. And like my professional colleagues have said the other time, I've worked in so many places, in Nigeria before I moved to United Kingdom. Particularly is my contribution to the development, smoke processing in surgical processing in at Lagoon Hospital, for about 5 years before moving to Evercare Hospital as a theater manager. Like she rightly said, it's a greenfield project, I got employed when the building was not even yet completed. Then, in order to put together the SOPs and, some other documentation that will serve as a guideline for surgical process and standard of practice in the operating theater. So we're going to move, like I said. So today we're going to be looking at principles of electrosurgery. So when we talk about principle, we want to look at guidelines, the step-by-step things that we need to do, things that we need to put in place if our electrosurgery must deliver, if we must have a very smooth and a very, nice looking surgical feed and, a healthy patients. So those things we need to do, those things we need to adjust, the settings we need to put together, because we know that surgeries are not the same. At some point, one surgery differs from another, and the kind of settings we have on all our surgical equipment differs from one another. And there's no exception when it comes to, the electrosurgery, also electrosurgical unit also. So, by way of history, there is no how we're going to be talking about electrosurgical units without talking about these two, great men. They developed modern electrosurgical units. The meaning is that there have been a rudimentary way of getting patients sorted and all those things. But at some point, the Dr. W.T. Bovey came up, put some things together and tried it on animal. At some point, he had to collaborate with Dr. Cushing, who is a neurosurgeon. So this modern day electrosurgical unit, the first time they tested it was in the year 1926. And of course, there have been a very great improvement in our electrosurgical unit. The one we are seeing was not the one they were using then. So all thanks to all these physicists, surgeon, theater users that have contributed so much in the development. Now that we now have a very comfortable, without even, as a surgical team, without even thinking on what kind of settings do you want to put in place in order for you to ensure that patient is safe. Now, by way of definition, what is electrosurgery? Of course, the term refers to the use of high frequency, and these are cogent, words when we are defining electrosurgery. High frequency alternating electric current to produce heating in tissue. High frequency, and it must be alternating. It must be an alternating electric current, not a direct current. When we go back, to our knowledge of physics, while we're in college, in secondary school, we talk about direct current and alternating current. Of course, they all have their importance, but in this case now, we'll be talking about alternating current to produce heat in order to have a good effect on the tissue. And we said that heating can be used to achieve various tissue effects, such as cutting. You want to make an incision, you want to ablate tissue, or desiccation, or a combination of effects. You want to coagulate at the same, you want to cut, and all those things. How do we need to go about it if not for this kind of invention? Now, for us to understand the principles that surround electrosurgery, we must understand rules of electricity. Because remember that this electrosurgery, we're actually passing a electric current into this patient in order to achieve, a good tissue effect. So for us we must understand, of course, I believe we have biomedic personnel amongst us. We are all theater users. However, apart from the medical engineers, as theater users, surgeons, nurses, anesthetists, scrub tech, and every other professional in the operating theater, we should have this. Even if it's going to be at basic level, we should have all this basic knowledge, so that when these diatemy or whatever is not giving us the good effect, we can at least put a bit of troubleshooting before we escalate further. So, and one of them is electricity always seek a ground. Just in every, of course, maybe probably in Africa, is so pronounced that when they build a house, they will have to put some, what's it called, a kind of wire and buried it into the floor. What is the essence of this wire? So that when there is an electric spark, rather than affecting the people inside the building, this earth, they call it earth, will receive the electricity and transfer it. In fact, at times it happens and people inside the building may not even know that this has happened, but because of this grant, everybody, seems safe without even knowing what has happened, to their electric current. Another point is it will always follow the path of least resistance. Now, that's another property of electricity. Electricity, when there is a flow of current, they will look for possible means to when electric current is moving, they look for a possible means, to stand against resistance. They just want to have a free flow. They don't want anything disturbing them. So when electric current is moving, they look at possible, least resistance for them to pass. And another point is electricity must complete a circuit or will not flow. That's very, very important. And even as a theater user, we need to know this, that a cycle must complete before another. It doesn't just move and they just move just like that. There is a cycle that has to be completed before another successful circuit will take place. Now we need to know some, we need to know one or two things when it comes to electrosurgery, basically maybe from their resistance and things that needs to be put into consideration in choosing the kind of settings you want to use during surgery. And one of them is different patient tissue has different level of resistance. Earlier I said that when electric current is going, they look for the possible least resistance when electric current is moving. And that's what we are saying. The same thing here, that different tissue has different level of resistance. Take, for example, a patient that wants to have surgery for the first time, compared with a patient that have had 2, 3, 4 surgery, that now had, scars and, adhesion and all those things. The team will find it very easy to use the electrosurgical unit in a primary patient that have not had surgery, because everything is just going to go smoothly, unlike a patient that have had surgery that is not having scar formation. They have to struggle with the use of diathermy. Then another point that we need to know, which is very, very germane, is that physician may opt for the bipolar method if the patient has implanted life-saving device. Take, for example, of course, the most common life-saving device that we see around is a pacemaker. And this is very, very important, that it must be established even right from the time patients enter into the hospital at the first consultation, that all these artificial attachment, all these devices must be well established if patients have them, and must well spelled out, so that everybody that will be handling this patient will have to take caution as regard whatever they want to do. If the pacemaker is going to be on their way, I remember, in the cath lab, there are some procedures that whenever they want to do in the cath lab, they will have to switch off this pacemaker so that there will be no, current interference. So the same thing, even in the operating theater, as much as possible, this pacemaker may not be in our way, but we need to know, and we need to put all this modality in place. Then, when we are talking about electrosurgical unit, what are those things that we put together to actually call it electrosurgical unit? So electrosurgical circuit needs the generator or electrosurgical generator. Then active electrode must also be available. And patient or tissue, of course, when you get all these things, the tissue you are going to use it on must also be available. Then return electrode in the case of if you are using monopolar, return electrode that will take electric currents, from the body of the patient back to the generator. Now, we're going to look at the working principle of electrosurgery. And one of the points is the generator takes current from outlets. Now, this is, the current that is coming is a direct current. Remember, I said it some few minutes ago that we are going to be dealing with alternating current. So the current going to the patient is an alternating current. But by the time you plug the generator, you are plugging the generator to a direct current, DC. So, the flow of current into the generator, of course, by the time it gets to the patient, it will have been converted into an alternating current. I don't want to, dwell much on all those, parts of the generator that actually convert a direct current into an alternating current. Now, the heat created is responsible for cutting. By the time this heat is created, of course, you achieve your desired aim. Do you want to cut or you want to coagulate? Now, what happened on the tissue by the time you apply? I'm just going to dwell on it. It actually happened at the cellular level. Of course, we are looking at the tissue and you are applying your diathermy pencil either in monopolar or your bipolar pencil. You just see that things happen, but the real place where those things you see actually happen, the mechanism behind them is that the heat actually goes to the cellular level, and that is where the desired tissue effect, of course, that you see is actually being put in place. Then also, electrosurgery works by cutting or coagulating tissue via a high-frequency electric current that I've talked about that is generated from the electrosurgical unit or ESC. The electrical current travels through an attached device. Now, this is the case in the case of a monopolar. The electrical current travels through an attached device. We call it active electrode. Of course, that's your diathermy pencil and all those things, and create localized heating to allow for precise cuts or coagulation of the tissue, which helps to reduce the risk of bleeding. So the desired effect, the aim of using this diathermy is actually to prevent bleeding. As we all know, when there is excessive bleeding, of course, the surgical site will be obstructed and a lot of things can actually go wrong. Now, this tissue effect we are talking about can be in the form of cutting, can be in the form of coagulation or desiccation, and can be in the form of, fulguration also. So we want to look at now factors to achieve tissue effect. There are 5 different factors to achieve this tissue effect. By all we do in the theater, we use the diathermy, but this diathermy, the process must go through these 5 factors to achieve the desired effect. Number one of them is, the current density. As expected, the greater the current that passes through an area, the greater the effect. This is just, this is very straightforward. The density of the current that passes through the active electrode, of course, will determine how effective the effect on the tissue. Then another factor is the time. I remember in one of our surgical case, back home in Nigeria, the surgeon was to use what's it called, ligature, and immediately he puts on the ligature, they put the ligature on the tissue. He did not allow for time. This thing, of course, these are the development we have actually talked about, because take for example in that ligature, the cycle and the number of seconds has been there. Once you press, once it gets to the number of seconds it should work, it will stop automatically. But in this case, of course, this surgeon just put it and just press it once. Of course, he began to complain that this thing is actually not working. It's not uh it's not, it's not seeing the effect he actually wanted to see on the tissue. But as time goes on, we all get on the same page and things actually. So the timing is very, very important. That when you put it, of course, you must allow a desired time for you to have the desired effect. Too short an activation will result in absence of the desired tissue effect. Very too short. Once you put it, you just take, for example, in monopolar, you just press on the cord without going through the length of the desired length you actually want to cut. You are not going to achieve it. Or when you are coagulating, the same thing also happens. Well, the third factor is the electrode size. So we said with respect to electrode size, smaller electrodes provide a higher current density and result in concentrated heating effect at the site of the tissue. Take for example, in pediatric surgery, when we are operating on neonates, we actually want this diathermy, this pin tip, because we don't want any spread. We just want the heat to be concentrated. The diathermy tip for neonate is actually like a needle point. So once we put it, you don't want it to spread, unlike the normal conventional diathermy tip. So the electrode size also determine the kind of current, the density of the current that is passed across, and also the tissue effect. Then number 4 is the tissue conductivity. Like I said earlier, that different tissue have different level of resistance, and in this case we can see that in adipose and bone they have high resistance, and that is why many times when we get to the adipose tissue, you have to put a lot of, you have to increase the current in order for you to have a desired effect, because they are poor conductor. They just begin to, absorb the electricity. So it will take more time in order to achieve the desired effect, unlike in muscle, that once you put it, you get your desired effect. Then the 5th one is the current wave, the waveform. And it's the final, of course, there are 5, and that's the final determinant. That's the final factor. The final determinant of how tissue respond to electrosurgery in the current time. Electrosurgical unit produce 3 waveforms. So we need here now, this waveform actually, they produce 3 waveforms. We have cut, we have blend, and we have coagulation. I know we begin to cast our mind back to the diathermy we have in our various, operating center, and you begin to look. You see cut, you see blend, you see coagulation. This cut, blend, and coagulation are actually the waveform. So a pure cutting waveform is continuous. Now, these are the principle, the working principle of these our electrosurgical units. The waveform is continuous. That is in cutting, unmodulated and undampened. It's continuous, and that is why we could, of course, for as long as you are cutting, because it is a continuous what's it called, waveform, you begin to get the desired cuts. You can cut as any centimeter you want to cut, because the waveform is actually a continuous one and unmodulated. But in the case of coagulation, when you are coagulating, what kind of waveform is applicable to coagulation? Interrupted one. So in this case, it's not continuous, it's interrupted one. Interrupted, modulated, and dampened currents. That's what we achieve. That's what we see in coagulation. But when it comes to blend waveform, what do we see? Is a modification of both cutting and coagulation, which is most of the time what we actually use, because in the case of monopolar, you just want to have a balanced waveform, and you can see the percentage. So when your diathermy is in blend one, you have 80% cut and 20% coagulation. And like I said earlier, depending on the kind of surgery you want to do, the surgeon can say, okay, put it on blend one for me, or put it on blend two. Now, when the surgeon is saying put it on so settings for me, is to achieve the desired what's it called, tissue effect that the surgeon feels is better and is going to be safe, for the surgery. And look at the what's it called, the waveform. Look at them in graph. You can see the pure cuts, a continuous unmodulated, undamped waveform. You can see that. Look at the blend one, the blend two, blend three, and the coagulation. You see that in coagulation is actually interrupted, and you can see the space on the graph. Unlike in cuts, that the space is not there because it's a continuous one, but this one is interrupted, and you can see the blend also, the way they go in sequence, blend one, two, and blend three. Now, we're going to talk about the difference between monopolar and bipolar, because it is very, very important, at least for us to know the difference, that when a surgery is being booked, by the time we are preparing, you already know what kind of the electrosurgical units you want to use, what kind of diathermy setting you want to use. Are you going to be using a monopolar, or you are going to be using a bipolar? And that is the essence of this slide. We can see the picture. We can see that the electrosurgical generator, and we can see how it travels to the patient. We can see the return electrode and the flow of the current. But in the case of bipolar, we can see that everything comes from the generator to the patient's tissue, and also back to the generator. And of course, some people, at times people will ask in the theater that why are they not using bipolar? I remember many, many years ago in the operating theater, we wanted to do a neuro case, and we are going to be using bipolar, and somebody puts what was it called, the atomy pad on the patient, of course, because that's individual. I think that was his second week in the operating theater. They don't know, but now the individual knows more better how electric current is passed and how they go back to the generator. So these are the difference between monopolar and bipolar. Also, we need to know the difference between electrocautery and electrosurgery. Literally, these words are used interchangeably. Just nominal. Interchangeably, we use electrocautery, electrosurgery, we use them. Somebody is talking about electrosurgery, is talking about electrocautery. Literally, people assume that they are all the same. But in the real sense of it, no, they are different. Electrocautery is actually different from electrosurgery. Take, for example, in electrocautery can only coagulate. While in electrosurgery, of course, we have both cutting and coagulation. So electrocautery can also, of course, which is also known as thermal cautery, use a connected device with a heating element. But in the case of electrosurgery, create high frequency alternating electric current that pass through the tissue, resulting in cutting and coagulation. Take for example, when a patient is having, bleeding in the gum, and they just bring this patient into the theater, most likely what they are going to use is electrocautery just to achieve, just to cauterize the bleeding vessel. While in electrosurgery, we achieve both cutting and coagulation. Now, the use of electrosurgery. Electrosurgery provides numerous benefits, including, but it's not limited to, number one, minimizing bleeding at the application, because very, very important. In fact, that's a major aim in order to reduce bleeding. You want to have a clean, very clean surgery. At the end of the day, at the end of the surgery, you don't want your patient going back to either ICU or back to the surgical ward, and you are calling for blood transfusion. The use of electrosurgery will reduce your rate of bleeding very, very drastically. Another use is that it allows for greater precision with cutting and coagulation setting, rather than gone are those days where a surgeon just pick the knife, and by the time they make the incision, by the time they put what's it called, retractor, this incision just go, very blunt dissection of the tissue. But now with electric, you just make a very small incision. Take for example, when you are doing in appendectomy, you want to put a very small incision. By the time you put your retractor, of course, it gets widened with blunt dissection of the tissue, and you do what you want to do, so that by the time you finish, you have a little, what's it called, closure, very good healing effect. Patient, after months, years, this patient will just look at and say, it seems like I've not even had any surgery. Another use of electrosurgery is it offers a relatively fast method for tissue resection. Because, I mean, when in surgery, by the time you use this electrosurgery, it gets things very fast, very clean for you. Then now complication. I'm almost ending because I know that our time is fast spent. Complication of electrosurgery. The complication, actually, the major complication is excessive heat, which is born actually to any structure where it is wrongfully used. But something that is very important is how this complication comes, how this complication actually, actually comes is the most important thing. Take for example, a trauma injury result from following situation. Now, direct application, which is always unintended. In surgery, we need to be very, very careful with all these electrosurgical units. When it's not being used, they should go back into their quiver, so that we don't just throw it, usually just drop it in between the patient leg, and unknowingly, unintended, another instrument can fall on it and activate activate the pencil, and of course it gives patient burns. Then another way by which these burns actually come is by direct coupling. We can see this picture. This is a case of laparoscopic surgery. We can see that two good conductor lying side by side. One is the active electrode, the other one is the laparoscope. Now, the bowel is just right beside, very close to them. This electric current is passed to the laparoscope, which is a good conductor. And this good conductor resting on the bowel, of course, gives these burns on the bowel. And before you know it, you want to do a bowel resection. Then another is insulation failure. We can see from the picture now that the insulation, when the insulation when the integrity of the insulation is not there, we could see from this picture that there is a break in insulation. And most of the time it happens, with excessive usage of instruments, excessive usage, even though many of them are reusable. Of course, we need to be very careful with them. And how do we get careful with them? Is by careful inspection. We need to let the CSSD know they need to inspect this instrument for the integrity, because if it's not there, of course, the risk is very, very high of getting the patient's structure burnt. Then, in conclusion, a thorough knowledge of the fundamental of electrosurgery by the entire team in the operating room is essential for patient safety and for recognizing potential complications. Everybody needs to be on the same page in the operating theater as per knowledge about electrosurgical units, so that when the surgeon is asking, or when the surgeon is saying, this is the kind of setting I want, everybody in the operating theater, particularly the circulating nurse, the scrub nurse, and every other individual in the operating theater really know what the surgeon is saying. So the knowledge must be for everybody, irrespective of where they belong, irrespective of their training. Everybody needs to, be on the same page. And this is where, the biomedics actually comes in to make sure that training and retraining is done. Because the more people are trained, the more knowledgeable they have in the operating theater about equipment, about instruments, the more safety we can guarantee to our patients. And that brings me to the end of this discussion. Thank you, everybody.
Okay.
Are we together?
Yes, yes. Thank you so much, sir, for that wonderful presentation. Does anybody have any questions? Thank you. Can you all hear me? Hello?
Hello.
Hello, can everybody hear me?
Yes, I can hear you. Good evening.
Good evening. I was asking if anyone has any questions concerning the presentation or any contribution before we move to WhatsApp, to the WhatsApp session. Thank you.
Okay. Sorry, I don't know if it will be like a contribution or a question per se, but I think it will be much more of a contributing aspect, I think. And also, thank you very much, Mr. Nas Joshua OLUALA. Because of the presentation, he told us some parts of the diatem and the electrosurgical unit itself. When he was mentioning about the bipolar, I was trying to get to where he talks about the foot pedal, foot switch.
Okay.
Which I didn't get anything about the foot switch, because sometimes I've seen some device, some unit having the hot yellow and that is orange and the blue buttons on the switch. But most of the times when you try to use it, you notice that it only serves the function of coagulation alone. So why having the blue on the foot switch? That is the question I have. Then the issue of this. Then the second one is about this grounding. You mentioned the earthing something, the earth where the current pass through the building itself. Hello, can you hear me?
Yes, I can hear you.
All right. I don't know. Some operation beds do not have the provision for this grounding system. I don't know what's the best possible. I say operation bed. Some of the machines, the surgical units do not have a provision where you plug the cable to your grounding system. I don't know what advice you give for individuals using such kind of machines.
Okay, thank you so much, Emmanuel. concerning your first question, so sorry that I didn't mention the foot switch. Of course, this is a common thing in the operating theater. That was the reason why I didn't mention it. However, you talked about foot switch having both blue and yellow foot switch for a bipolar. Anyway, I don't know. I have not seen that before. For all the bipolar that I've worked on, they have just a single foot switch, which is actually black. However, if that is what probably in your center, because the foot switch that have both blue and yellow, where I want to believe that should be for a monopolar. I don't know if they use it for bipolar, but if that is what you guys use, of course, you have to be very sure that there is no risk of complication using that. If there is any risk, then of course you need to raise it, with the concerned department so that they can, do something about it, because patient safety is the concern for everybody in the operating theater, from the surgeon even to the cleaner, even to the porter. Patient safety is of great concern to everybody. Now, concerning your second question, that some of those beds don't have grounding. Then if they don't have this grounding of the thing, how are you preventing patients from what's it called? Complication, of course, which is excessive heat that can give rise to burns, in patients. I don't really know. I want to believe that most of these beds have it, but if you have a concern, I will advise that you should talk to the biomedics, probably is on the bed, and of course, people may not, because most of the time it used to be underneath where you put, by the time you put, what's it called, you apply the brake, it's always, once you apply the brakes, it always also come down and hit the ground, so that it serves as a very serious insulator to receive, what's it called, to receive excessive current that may have been passed into, to the patient. So I want to say that the biomedics would actually do a very good job in showing you if you have a concern. That would be my advice. Anyway, thank you so much.
Thank you so much. Thank you so much. Thank you for that very detailed and enlightening session of the presentation. So without much ado, would like to move over to the WhatsApp so we can share the slide. Mr. Lola, can you be able to share the slides to us tonight?
Yes,
hello?
I'm going to send the slide to you.
Oh, okay. So I can share it to the WhatsApp group so that those
please.
will be able to see what we've done so far. So on behalf of the operating room global management, I want to thank us all for making our time to be here and tonight's meeting. Thank you, very esteemed President Ms. Adebisola. I see you. Thank you for joining us tonight. Thank you. Good evening, sir. Thank you for joining us tonight. Amos-san, you're welcome. Thank you for joining us. Thank you for joining us tonight. Mr. Manuel, thank you for your contribution and question. Thank you for joining us tonight. And Joyce, thank you so much for joining us tonight. I want to say a very big thank you to our key presenter tonight, Mr. Joshua. Thank you for honoring an invite and for making tonight's session a very educative one for every one of us. So when next we see, I want to wish us a very great night. And once again, thank you. All right, ma'am. We can end the meeting now.